everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios at ACTN. On tonight's program, we're going to continue our discussion on ear, nose, and throat medicine. With me in studio tonight to give his expert opinion is Dr. Rabindranath Maharaj. Dr. Maharaj is an ENT consultant surgeon based at the Gulfview Medical Center in Laramie. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So guys, let's get the show going. Let's talk ear, nose, and throat medicine, and let's say welcome back to Dr. Rabindranath Maharaj. Doc, welcome back.
Thank you. Welcome.
All right. So,
good night to our viewers as well.
Good. So Robin, last time you were here, yes, we were a bit ambitious. We went through a lot of stuff.
Yes.
We put out a lot of information. We went through the ears, nose, we did a bit on the throat. However, last time we didn't get to cancers of the head and neck, right? And we said that no matter what, we're going to take our time and go through cancers of the head and neck with the population. And we're going to give them the relevant information. So, Robin, that's the start of the discussion, right? Why is it so important for our viewers, our community at large, to hear about the signs and symptoms of head and neck cancers?
Yeah.
Why is it important? Right. Is it a common problem in Trinidad?
So cancers on the whole, I think that it's on the rise.
Yeah.
Head and neck cancers only account for about 4% of all the cancers that we have.
Right.
So it's not that common compared to some of the others, but they do exist. And some of the data we had, at least in San Fernando General, over the last 10, 20 years actually,
yes,
showed that there was a little rise, and we need to be aware of that because, you know, picking up these things early is the key thing for our viewers, and that's the most important thing in terms of a message that I would want to get across tonight. If we can pick up these things early, we can actually cure you. A lot of people, you know, when they hear the word cancer, it seems like a death sentence, but actually, a lot of them we have cured, and the key to it was really picking it up at the early stage. A lot of our patients actually came in at later stages, and those, unfortunately, are hard to cure.
All right. So, yes, cancers in general is an important thing. We have that's our job as doctors to put out the information there so our patients go for early screening. So we pick up on these cancers no matter what it is, whether it's breast cancer, colon cancer. But is it what is it in a lot of times, right? I mean, generally, I'd find that a lot of patients present late.
Yeah.
Right? Is it because, I would think as a practitioner, it's because the patient don't get really much pain, or it might be something that's easily missed or easily overlooked. For example, a patient will tend to go to the doctor if they get a lot of pain and so on, right? Yes. So a patient might observe something on themselves, they're not getting much pain, or they might be hoarse, and that's not a major thing to stop them in their life, so they might put it off. And I think sometimes they put it off going, well, look, you know, the hoarseness is not going to stop me from doing my day's activities. I have to drop the kids to school, I have to go to work and so on, and they keep putting off things that are not affecting them, and maybe that's why they present late?
Correct. And the key to this is to know what to look for.
Right.
So that once we know what to look for as a patient, then, you know, we'd pick it up much earlier. And a lot of symptoms that patients have, they ignore it, as you say.
Right.
Yes.
All right. So Robin, let's get straight into the particular types of cancers in the head and neck, right? So let's go straight to the throat area.
Yeah.
All right. So how would someone at home know that they have throat cancer, right? Or you could break it down to the different types. Yeah. And I'm just putting forward like from what our community would need to know.
From a broad perspective.
A broad perspective. Yeah. And what causes these cancers of the throat?
Right. So, as I said, it's not a common group of cancers. 4% of all cancers, but in that 4%, the commonest set of head and neck cancers that we see would be what we call cancers of the larynx or the voice box. So it's part of the throat. The throat actually, if we were to break it down more specifically, you would have the voice box and the food passage or the pharynx. So cancers of the voice box tend to be the commonest ones.
Right.
followed by cancers of the oral cavity, more specifically the tongue.
Right.
So those are, I would say, are our top two cancers that we look at in the head and neck area. And then the others come after in lower numbers. So we will have cancers of the sinuses, even cancers of the roof of the mouth, cancers of the tonsils. I've even seen cancers of the ear.
Okay.
In the last 20 years, I've actually picked up 2 of those. So they're quite rare. But cancers of the voice box, I think it's a relatively common one in the head and neck area, and it is something that we can pick up early.
All right. So very specifically, what symptoms does the patient find?
So by far, the commonest symptom that you're going to look for is hoarseness.
Right.
Hoarseness is the earliest presenting sign for most of these cancers of the voice box.
Right.
And it's because the small changes on the vocal cords will cause a change in your voice. So once patients get hoarseness, now hoarseness by itself is a common symptom.
Yeah.
So not everybody who has hoarseness, of course, we have to be worried about.
Yeah.
So a few key points you need to be aware of.
Yeah.
One, persistent hoarseness.
Yeah.
So hoarseness that I would say lasting for more than 2 weeks or 3 weeks, certainly not more than 3 weeks, we as the specialist should have a look at it. So patients might get one of the commonest causes of hoarseness in terms of a short-term problem would be laryngitis, an infection of the vocal cords from a virus. So most patients, they get the virus, they get a little hoarseness from that, but it disappears within 3-5 days or so, and we don't need to see those patients. A patient who now going into 2 weeks and they've seen the primary care doctor, they've done their treatments at home, it's continuing to persist, those patients we need to see. And the other important point, other than a persistent hoarseness, is no pain with it. So a lot of people associate pain with something serious.
Yes.
And this message is across the board for all our cancers. And in head and neck, it's no different. Painless lesions are actually the earliest presenting signs as opposed to a painful lesion. In fact, if a patient comes with a painful lesion for a few days, most of the times I can reassure the patient this is not usually cancerous.
Right. So I just want to underscore that point there, right? Because especially in general practice, it's very important that people are coming up with any kind of lumps and bumps in their body, and they're not sure exactly what it is. The lack of pain should not stop you from seeing a medical professional.
Correct.
And what Dr. Maharaj is kind of pointing out there is that commonly enough cancerous lumps and bumps generally do not cause pain.
No. In the early phases, they do not cause
in the early
pain.
phases.
So patients will now watch it, they will leave it, mine it, as they say in Trinidad.
Right.
A few weeks will pass, it's still there, no pain, but then it starts to go into weeks and then months, and when it reaches a certain size, then the pain will start to come on. But we do not want to pick it up at that stage.
So, Doc, if the patient comes into here, they've been hoarse for a little while, they probably saw the GP, and we've dealt with cases like this ourselves together. They come in, sometimes we might say, look, let's just rest the voice, let's see how you go, let's treat you for acid reflux. But the key part at the back of the doctor's mind and back of the patient's mind when we have a discussion is if it's not settling, we're going to have a look. Right? And those patients normally leave our office as general practitioners and enter into your office as the ENT specialist. What do you do for those patients next, those hoarse patients? How do you know what's going on?
Right. So last week we had put up a slide. We could probably put it back up again. Josh, I think it's slide number 8. And that slide basically shows what we would do when the patient comes with
that's you there.
Yeah. And so we would pass the scope into the throat.
Right.
We may pass it from the nose into the throat, or we may go straight from the mouth into the throat.
Yeah.
And it's done sometimes with a topical anesthetic.
Yeah.
And other than that,
Yeah.
some patients can actually do it without any anesthetic.
Right.
So we would look and have a good view of what's going on in the vocal cords.
Right.
So there's a slide with what we would see. So we could probably put up that slide. Let's find that slide for you. So we could look at slide number 9 and then slide number 10. So when we pass that scope, a normal voice box would give you the view you're seeing on the screen now.
Right.
And the two white things you're seeing there, that upside down V, is your vocal cords.
Okay.
And they're supposed to look white. They're supposed to move and touch each other when we speak.
Right.
So if we go to the other slide, which is 10, you'd see the cord is no longer white.
So that's a normal one on the side.
It's actually a bit red. It should be white as well.
Right.
But it's a bit red. So both cords, I would say, they're not normal in appearance. But the one on the right-hand side is obviously looking irregular.
Right.
It's irregular. There's a mass on it.
Yeah.
And that is what we would see if we suspect cancer, a lesion looking something like that.
Right. So you look inside, you have to look down because the GP cannot see that.
No,
you look down.
Can't see that in your office.
So the patients at home, they would have seen what a normal vocal cord looks like, which is great for them, and the GPs at home. And they've seen another vocal cord that was red and erythematous, and one that has a cancer on it, right? Yeah. So before we continue on about that, right? What causes cancers in the throat?
Yeah. So cancers, and a lot of people ask that question. What caused this thing?
What happened?
And cancers would be a group of conditions. It's not one cause for every cancer. So our viewers need to know that.
Yeah.
So in head and neck cancers, the big risk factors would be alcohol, cigarette smoking, and recently we've been noticing a few related to viruses, more specifically the human papilloma virus and the Epstein-Barr virus. Okay. So those are other risk factors that we see, but cigarette, I would say, is by far still the biggest risk factor.
All right. Does acid reflux contribute to it? So, because that acid reflux is a really common complaint.
I would say everybody has acid reflux at some point in their life. Yeah. So no need to panic if you think you have a little acid reflux. Right. 98%, 99% of patients with acid reflux will not get cancer, but there will be the 1 in 1,000 who may have severe acid reflux, and that may irritate the food passage, called the esophagus, the lower part actually. In most cases, and that can cause cancer. And it is suggested that if the acid is refluxing all the way up to the throat, it may increase the risk there as well. So yes, but I need to underscore that the point that is very uncommon. So don't think, I have acid reflux, my risk for cancer is through the ceiling. Right? Cigarette smoke still number one on the list. Alcohol, and in fact, if you do both, which a lot of people do, the risk is not just additive, but it's actually multiplies.
All right. So, Robin, let me just take you. So that's a vocal cord cancer that you're showing us there, right? So before we go into the other types of cancers in the head and neck, what happens to that patient there with that vocal cord cancer? What do you do next for him?
Right. So we see this lesion. We pass the scope. We look at the cords. We see this lesion. So over years, looking at these things, you can tell when something is suspicious. Yeah. So we say, this looks suspicious, but I cannot diagnose that as cancer officially at that point, because to make the diagnosis finally of cancer, I would now have to do another procedure where we would take this patient into a theater to do a biopsy. Right. And a biopsy basically means taking a small piece of the tissue to send to the lab so the pathologist can look at it under the microscope to confirm it is cancerous. Right. So that would be the first thing we need to do a biopsy, and that is done under general anesthetic for this particular condition. Right. Once we get a confirmation on the biopsy, the next thing we need to do is understand how far this cancer has grown and how far it has spread, so that it will tailor our treatment. Now, a very important point with head and neck cancers, in the medical fraternity, we will refer to these as squamous cell cancers. The majority of these arise from the lining of the food passage, the voice box, and because of that, in the very early phases, if you do scans, CTs, MRIs, certainly not X-rays, they will not show anything. But CTs and MRIs will miss a very early stage 1 cancer.
Right.
So that is not going to help the diagnosis in most early cancers.
To help stage it.
Yes, it helps to stage it,
Right.
but looking at it directly is what helps us to pick up the early ones.
And the histology.
And the histology.
Right.
Once we pick up the diagnosis, now we do the scans, the CTs and the MRIs, and more recently something called PET scans,
Right.
to get an idea of how far the cancer has spread, or as you refer to it, the stage of the cancer.
Right.
So once we have those 2 bits of information,
Right.
then we start considering treatment.
All right. So I think you have some slides just to highlight that. All right.
Yeah.
Yeah. Before we go on to the next part of the treatment, let's back up those slides so we could run it through visually.
Yeah. So we went through the ones with the
patients have a
investigation. So that would be slide number 11.
Right.
And just to highlight it.
Yeah, I know you spoke through it.
Yeah,
But let's just show it. So the biopsy
Yeah.
that they go through when they have that stuff there, the
Right,
histological
so
diagnosis.
we take the biopsy, we get the histological diagnosis. Then we do the scans to get an idea of how far it has spread.
Right.
And then that gives us an idea of the size, as well as if it has spread to other parts of the body. And then we start treatment.
Right.
So
What's the treatment?
So when we look at treatment, so if we look at the next slide, I put up this because treating cancer is not a one-man show. It's not a one-man job, and it should never be undertaken as such by any practitioner. It is a team approach, and as such, we would want to have a number of people on our team. So the head and neck surgeon will be one of the main people.
Of course.
Then we would have somebody called a medical oncologist. So they deal with the drugs and the chemotherapy part of it. And then you have somebody called a radiation oncologist. So they are another cancer specialist, but they deal with the radiation part of it. And then you have the other part of the team that will be also just as important. And they will involve people like the pathologists who will help us in terms of giving us the precise diagnosis. We will have people like the dietitian, because nutrition is extremely important, especially in head and neck cancers, because remember, patients may not be able to eat properly. They may not be able to swallow properly.
Right.
So nutrition becomes very important for these patients.
Right.
Then we may have people, again, called speech language pathologists. We refer to them as speech therapists in the past, but the proper terminology is speech language pathologists. And they help the patient in terms of speaking as well, because remember, their voice is going to be affected.
Exactly.
So it's a whole team approach, and we need to get everybody on board.
All right. So that's great. So we spoke through the laryngeal cancers, the cancer of the voice box. Now, Robin, what's the prognosis for these patients?
So, and that, again, just to underscore what we said at the beginning, we want to pick up these things early, because if we pick up these things early, we can offer patients a cure.
Right.
And normally for cancers, for patients, we would divide them roughly into stage 1 to 4.
Right.
So stage 1 being the early cancers, and stage 4 being late stage cancers.
Right.
So we want to pick up these patients at a stage 1 and possibly a stage 2 at most. And if we can pick them up at these stages, we can cure patients. And when I say cure, so when we say cure, we in the medical field, we refer to it as a 5-year survival rate. It doesn't mean that everybody is going to fit that exact figure, but people who are stage 1 certainly in laryngeal or voice box cancers, they have a 90 to 95% cure rate. 90 to 95%. Those are really good odds. And I can tell you from patients who we've seen and who were treated, 10 years down, they're still doing well. So it is we can offer them a cure.
Right. So the last 10 minutes, we've been talking about laryngeal cancer, right? And the first question I ask is, why is it important that you bring this message here? So the patients at home, yes, you deliver the message in a very simple way. But obviously, some people still might not fully grasp, right? But the take-home message of why we're doing this show, why you came in here, why you sat here, why you left your busy office, and why you're talking about something so specific as head and neck cancers is, one, because the symptoms, sometimes people might not be sick or get pain, or this might have hoarseness. But the second part it is, if you pick it up early, and that's why you are here to tell people that if you pick this cancer up early, you have a 95% chance of saving their life and curing them. And it'd be a real tragedy. It's a tragedy that we have these facilities available, we have the expertise available in Trinidad, we have the information, and sometimes we still pick up people too late and we lose lives.
They slip through the net. They slip through, and you will always have a few. But the thing is, the more the message gets out there, the less will slip through.
Exactly. So I think with that underscoring of the importance of why you're here tonight, I think we're going to take a little break. Right? We'll take a little pause and then we'll come back. So guys, we're here with Dr. Rabindranath Maharaj, Robin Maharaj as we fondly call him. He's here tonight to talk about cancers of the head and neck and one or two other complaints in ENT medicine if we get a chance. I'd just like to formally invite you to send in your messages and your questions to us now, and Dr. Maharaj will answer them. All right? So we'll take a 1-minute break and we'll be back shortly.
Football 101 is on every Tuesday and Thursday night at 9 p.m.
I'm your host, Josh Rudy Matos, and I'm joined by Nikolai Madry, Jeremy Bridgenath, and David Lucky.
This is where you'll get all the football news that you need to know.
Glamorize football to what it is. The viewership speaks for itself. At the end of the day, these guys are making billions on viewership.
With heated banter,
they'll have more trophies, more Premier League trophies, more
You are talking past. You are talking past. I'm talking about current situation of the club.
and trending discussions.
Barcelona was built around Messi.
Well, Messi created the most chances against Real Madrid in the Champions League.
Covering all the major leagues.
If you all don't win Europa, you can hold us. This is the only cup you all are going to hold.
Failure to support their core coaches with the kind of budget.
I think you have somebody delivering some food for you. We need to get service like this on the show.
Yeah, I can do some of that right now. It's about that time.
Football 101, bringing the field to your home.
You have the most assists right now.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. Your health, your choice. We're here with Dr. Rabindranath Maharaj, ENT surgeon. We're talking about ENT cancers. So we finished laryngeal type cancers, and we're going to go on to talk about some other cancers in the head and neck. But at this point in time, it's very important to let you know that some of the pictures that we have might be a little bit mildly graphic for some of the younger viewers, all right? We're going to show you some pictures of the cancers. And I think it's important that we show you these pictures. And you could also send in your questions and your comments to Dr. Maharaj in ENT medicine as well. So, Doc, let's move on directly to tongue cancers, all right? How common is cancer of the tongue?
Right, so tongue cancers, as I said, they rank number 2 amongst the head and neck cancers. Laryngeal or voice box cancers being number 1.
Right.
So it is fairly common amongst the head and neck. In the last year, I would have probably picked up about 2 or 3, which is a lot.
Okay, that's a lot.
Which is a lot for our South population. And again, to emphasize the point, a lot of patients, they get these little ulcers. So that's how they will present. They will present as a solitary single ulcer on the tongue.
Right.
And again, no pain in the very early stages, so patients will ignore it. They'll see this little sore there and they'll say, okay, it's not paining, so it can't be serious.
But then again, patients might also be accustomed. I mean, people get all kind of little bits and sores and ulcers on the tongue.
So again, the next big important point is persistence.
Okay.
So you see an ulcer, if it's a traumatic ulcer from biting the tongue, that will heal within a week or so.
Right.
Most of them. If you see an ulcer or sore on the tongue that is lingering beyond 2 weeks, you know, we need to check that again. So that magic number of 2 weeks.
Don't ignore it.
Don't ignore that painless ulcer.
And I interrupted you when you said that magic number of 2 weeks.
Yeah, because as I say, most simple conditions will settle because you will have a lot of other causes for simple ulcers. One is called canker sores or aphthous ulcers. Those tend to be painful or stress ulcers, we call them as well. And the key is these will be multiple as opposed to one ulcer that is painless and not healing.
All right, so the best way, right, to teach people about something is to actually show them it, right? So, Robin, if you could just show us
so let's look at
a few pictures of what tongue cancer look like.
Let's look at slide number 21. So slide number 21.
So these are the kind of ulcers that the patient would see on the tongue and they need to come into.
This is actually, for me, a relatively late stage ulcer.
This is definitely late stage.
And you don't want to have something that big in the tongue. You'd be surprised patients will leave something like that and come at that stage sometimes.
Right.
But you do not want that, because at that stage you will get pain, because that lesion has now infiltrated the surrounding tissues. It has infiltrated the nerves. You will get a lot of dead tissue around it, so you get a bad odor sometimes coming from the mouth. The muscles are affected, so you can't open the mouth properly, you can't swallow properly. So this is a late stage cancer of the tongue that we do not want to pick up at that stage. So if we go to the next slide, you'll see another late stage one. So that one is also big. But if we go to the slide after that, so if you look at it, I put two pictures there. One on the left-hand side, which is actually a very small, very insignificant appearing lesion on the tongue. And that actually was an early tongue cancer. And I put something on the other side, a small lesion, which is a bruise. So like somebody bit the tongue or denture scraped it and it wasn't healing. So that's a traumatic ulcer. And the difference between the two in the early stages was the traumatic one was very painful. That one on the left, which is a more serious one, is actually painless. But that is the one I want to pick up.
All right. So would you recommend that patients actually look routinely?
So the good thing about tongue and oral cavity is you can inspect it. You can see it, unlike the
which is the value of why we show those pictures to the public.
So you can look at it and you can see what might be serious in the early stages. And so if you notice, again, just to emphasize, one ulcer, not multiple. So multiple ulcers usually do not imply cancer most of the times. Painless small lesions could be serious. Painful ones might be less serious. The slide after that is an even earlier stage of what we call a precancerous lesion.
Okay. So could you put that up there, Josh? So we're taking the viewers through what is a late stage cancer. They can see it. What is an early one? And now we're going to show them pre-cancer, which is where we want to catch them.
So that's even earlier than cancer.
You might have to help Josh there.
So that's slide number, I think 14 was it? Let me just tell you. No, sorry, it's slide number 24.
Josh. So that would be slide number 24 would be the pre-cancer. Is that it there?
Yeah, so that's it. So it's white patches on the tongue. We refer to it as leukoplakia. And those lesions are not cancerous, but they have a high chance of becoming cancerous. So not all will become cancerous again, but probably about 10-20% of them over the course of a year or two could turn into a cancerous or malignant lesion. So that is actually the earliest things that you might see in your mouth. Now, again, a lot of lesions can give you white plaques as well. The commonest one being thrush. So people will see white patches sometimes on the tongue or in the cheeks, and that might be from thrush, which is a fungal infection. And those may come up and they will disappear within a week, or with treatment they will go away certainly within 2 weeks.
Right.
So thrush can look like it, but it doesn't linger beyond the 2 weeks with proper treatment.
Okay.
There's another condition called lichen planus, which can affect your skin as well as the oral cavity, and it can give you white lines and white patches in your oral cavity. The thing about lichen planus is 10% of them can become cancerous as well. And one of the cases I had this year was a case like that. The patient had lichen planus, so they had these white lines and white patches in the oral cavity, throughout the oral cavity. So the dentist saw it, the dental surgeon looked at it, and they said, okay, this is lichen planus, it's not cancerous, we put you on your treatment. But 2 years down the road, this patient started developing an ulcer within that one of the white patches on the tongue. So the patient came to me and said, well, doc, I have lichen planus. Do you know how to treat lichen planus? So I said, sure, but let me look at it first. Because this patient is going through his last year thinking, well, I have lichen planus alone, and
nothing wrong there.
Nothing wrong, I'll just take my normal treatment. But the problem is this little ulcer, this little lesion came up and it wasn't healing. And of course, when I looked at it, it looked suspicious. So with years of experience, you look at these things, as soon as you look, you get this suspicion there. So the next step was biopsy, and it was confirmed cancer.
All right. So I'm really glad that you showed the viewers at home the different lesions to look out for on the tongue. So let's get back to it as well. What causes this?
Again, we come back to smoking and cigarette, alcohol.
All right.
So and the virus, the HPV virus, and that is similar to the virus that causes cervical cancer. So interestingly enough, this has only been observed in the last 15 years or so, where it was picked up as a risk factor for cancers in the mouth, but more specifically the back of the mouth, what we call the oropharynx. So viruses have been increasing as a cause of cancers in the oral and the oropharyngeal area.
All right. So the next big question: other than do you see patients with cancers in that area who does not fall into that risk category?
Yes.
Because we had patients that we worked on who never smoked.
Correct. So it doesn't mean that because you never smoked and you never had alcohol, because I could distinctly remember a patient like that as well. And cancer risks in head and neck certainly goes up with age as well. So over 40, the risk goes up significantly. But again, the exceptions stick out in your mind. And I always remember
that's the unfortunate thing.
18, 20-year-old girl, never smoked in her life,
of course.
never had alcohol in her life. And she developed an aggressive form of tongue cancer. And it was by the time she presented to us, we couldn't do anything about it.
All right. So
but those are the exceptions.
Those are the exceptions, and what the information tonight is to get these things early. Right. So you showed us the picture of what it looks like before his cancer. Right.
And just to add something on the risk factors, because people when they hear cigarette smoking, some people will ask, so what about marijuana, doc? And yes, smoking marijuana does the same thing. Marijuana has benefits, and yes, it's been legal, medically approved. But the smoking of marijuana can also increase your risk of these head and neck cancers, just like cigarette smoke.
Good point. And so about environmental pollution in other countries.
So environmental pollution, it could be a risk factor. Now, when they do their studies, they have a lot of controls to make sure there's what we call a strong association or a weak association. So cigarette smoke, marijuana smoke, alcohol, HPV virus, strong associations. Environmental pollution, it is suggested it can increase your risk of some of these cancers, not so much the tongue, but some of the other cancers in the head and neck, like the sinus cancers. So people who work in woodwork, so wood dust, asbestos.
Wear your mask.
Wear your mask. Right, because those increase your risk of cancers as well.
Robert, I just want to again we pushing you through again because of time.
Sure.
how do you treat it?
Right. So
Cancer of the tongue, this person comes in, doc, I have this painful ulcer on my tongue here for the last 2 weeks.
Yeah.
It's not going anywhere. I saw your program. You said once I have anything on my tongue that looking anything round and a little white, come in and see a doctor, right?
Yeah.
So they come in, they're by your office now, and what do you do next for them?
Right. So again, once it's beyond a certain time limit, so somebody within a week of presenting with a small lesion, I probably would not go biopsy so quickly.
Right.
I would give them the 2 weeks or 3 weeks because, as I say, there are other reasons for it. But once it's like somebody coming here for a month with this lesion, I would almost certainly look at biopsying it again, and then doing the scans, and then the primary treatment for the early cancers in the tongue, just like the throat, is either surgery to remove the lesion or radiotherapy, not chemotherapy at that stage.
All right. And the prognosis, what happens?
Again, 90% prognosis. I have patients who we picked up early, like what I showed you on the slides there, 10 years down, and they're fine, right? They're doing well, no signs of recurrence, which brings me to an important point.
Yes.
After treatment, we don't stop there. We need to follow up and we need to monitor. Yeah. So monitoring after treatment is a crucial part of any cancer, not just head and neck. And so initially after treatment, patients might need probably, your doctor might tell you a 6-month follow-up, or initially I would say 3 months, then 6 months, and then probably a year. And so certainly for the first 5 years, you should have at least a yearly follow-up.
Okay. All right. So that's the tongues. We went through the diagnosis. We went through the treatment, biopsies. So what other cancers of the head and neck that would you want our viewers to hear about?
So now we come to the less common ones, and those would be cancers of the salivary glands, cancers of the sinuses.
All right. So let's start with the salivary glands. All right. So can you just describe to our viewers where the salivary glands are, what they would see, or show them?
Yeah. So the salivary glands, we have a slide with a patient with a salivary gland tumor. That would be slide number 31 and then number 32. So we have some big salivary glands, and so this is on the side of the face, just around the ear. This is called a parotid salivary gland. That's the largest salivary gland, in fact, in the area. You have one on each side, and then you have salivary glands under your jaw. We call that the submandibular glands, and then you have some smaller ones throughout the mouth. We call them minor salivary glands. Now, most of the lumps in the parotid, which is the one you're seeing, most of them are actually benign. In fact, 80% of the tumors or lumps that you get in the parotid gland are benign or non-cancerous lumps. As you get into the other glands, actually, they tend to be more risky for cancer. But this one in particular, this is a patient.
This is your patient?
This is one of my patients from 20 years ago. And if you put up the other slide that followed this one, you would see a front view of the patient. So you can see the lump on the side of the face again. But why I put this slide is to look at the lip. It looks almost as if the mouth is being pulled to the opposite side, like a stroke. And the reason for that is because the nerve to the face passes through that salivary gland. And with cancers, the cancer invades the nerve and it destroys the function of the nerve, so patients could present with weakness on that side of the face.
All right, so let me ask you a question. Someone who comes in with that kind of, how swelling in the parotid gland, how long did he have that swelling before it became cancerous?
Correct, yeah.
So because people get parotid gland swellings, it goes down. I suppose, I know you kind of put forward a golden two-week rule here. But what happened? What happened that happened? You know, to that poor gentleman that had this cancer. What happened?
And I suspect,
why wasn't it? Why picked up before? Why did he have to have this
weakness in the face?
Yeah, this weakness. Why did it get so bad?
So patients, again, in the early phases, this would not have been painful. So he would have noticed a lump there, and he said, you know what? It's not paining me. It's not bothering me. I'll leave it alone. And so sometimes patients. So that's one reason. Another reason could be what I refer to as ostrich syndrome. Patients are scared to find out what it might be.
No, that's a real problem in medicine.
So they see this thing and they're scared now because they figure if they go, they'll find out the truth. But not finding out the truth doesn't change the problem.
Dr. Maharaj, fear is, we talked about this on previous programs as well, and fear fear is a big problem in medicine in Trinidad as well. And people, and as we said, kind of jokingly, fear will kill you.
Yeah, it will.
Right?
It will.
Fear will kill you. We kind of say that amongst ourselves as doctors. And that's why the importance of this type of program, that we educate people so that they wouldn't be fearful that negative, that's something bad. Because
again,
medicine has progressed so much.
And so we can treat and we can cure some of these. And so if he comes at an earlier stage with no pain, and a small lump, the treatment, we would diagnose it first. In this case, in terms of diagnosis, we don't have to go cutting the skin to get the biopsy. We can do something called a fine needle biopsy. And I have a slide of that actually.
Yeah, Josh, put up that one, please.
That would be slide number 28.
Yeah.
And so that is referred to as a fine needle test. So it's a needle almost like taking a blood sample, but you're putting the needle into this the swelling to take a small amount of tissue, very small amount of tissue. So it's no cuts on the skin. It can be done with a local anesthetic, and patient walks in, they have it done, the sample goes to the lab, and they walk back out. And within a week or two, they get a result. And that helps us. That will tell us sometimes. Just that test alone will tell us this is cancerous or not, and then we move on with treatment.
And is it causes the same smoking, alcohol?
No, not for salivary gland tumors. The risk factors are not that clear with salivary gland tumors. Previous radiation may be a factor in it. But like a lot of cancers, we don't know all the answers, unfortunately. So, if I were to go back to the start of this program and tell people, well, what is a cancer? Because people, they hear the word cancer and they just know it's a bad thing.
Go ahead, tell them.
And what cancer really is an uncontrolled growth of cells in your body, in a particular part of your body. Normally when cells grow, they grow in an orderly fashion. They have signals to tell them when to stop growing, and how big to grow. Sometimes that message comes from the cell, from what we call the genetic level. That is deep down into the cell. So the genetics will tell us that, okay, the cell will grow in an orderly fashion. Ever so often when this cell keeps dividing, you get an imperfect copy, right? So you get this imperfect copy of the genes now, which now has lost control of the proper growth of the cells. And so the cell starts to multiply uncontrollably. It starts to invade the surrounding tissue. So that's one of the hallmarks of cancer. And the other big hallmark is it spreads via the blood or other systems to other parts of the body. Those are the two hallmarks.
All right. So you take a biopsy of that parotid or salivary gland cancer and you take a diagnosis, and he goes for the same surgery.
Surgery in this case is the primary treatment.
All right. So you wanted to tell us a bit about sinus cancers as well?
Yeah. So again, the other slide that I have with this, we can look at slide number 30. And slide number 30 is actually in the oral cavity, but it's a cancer that arose from the sinus. And your sinuses, if you remember, in one of the slides last week, I put up where the sinuses are these air-filled spaces in the bones in your skull. So you have on your cheeks and on your forehead. So the ones on the cheek, the sinus on the right side on the cheek developed a cancer, and it extended, it grew, and it invaded into the mouth because the mouth is right underneath the sinus. So the patient presented with this mass in the roof of his mouth or the hard palate. So that is so sometimes patients might notice, well, older people, they wear dentures and the dentures start to not fit properly. It is important to remove that denture and look under it, because once you see some abnormal growth there, an ulcer, then you need to have it looked at.
All right. And what age group are those type of patients?
Again, the older populations, usually the ones I have seen in South were more in their 60s, and I had a patient who was 90 before she developed it. So, and the reason you tend to see it more still in the older population is as we get older, the replication of our cells develop more imperfect problems. So you get more imperfect copies of your cells. So then you end up with these abnormal cells coming up, which are the cancer cells.
All right. So I think we've covered most of the cancers. So I think that was a good time to take a little break, and we'll come back in 1 minute. So guys, we're here with Dr. Maharaj. Please send in your questions on the topic of ENT. You can send it in on cancers, but also the topic of ENT. And Dr. Maharaj doesn't mind. He'll do his very best to try and address your questions. All right, guys, we'll see you back in 1 moment.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
All right, guys, welcome back. We're here with Dr. Rabindranath Maharaj, ENT surgeon, and Josh has let me know that we had some questions. Josh, you could start with the first question, please. Good night. My mom has a head cold for approximately 1.5 months, with blood and mucus when blowing her nose, as well as lesions on the entire face and head. So a GP was treated for septicemia for the past 2 weeks, however, with no improvement. Should she be seen by an ENT specialist? You got the drift of that complaint there?
Yeah, well, the rash.
The rash is a little strange.
Yeah, it's a little strange because normally a sinus infection should not give you a rash unless it's a specific bacteria that you may get these little fine rashes, but you don't normally see that.
And I'm not sure if there might be a bit of misinterpretation from of septicemia.
Yeah, but certainly some key points for me to why I would say she needs to see the ENT at this point is 2 weeks has elapsed.
2 weeks, that was the magic.
And the patient is not improving.
So I guess the message went over.
Right, yeah.
The hallmark golden time frame, if everybody remembers something out there, is if something not resolving in ENT medicine after 2 in your face, your head, your neck, after 2 weeks, go back in to see a doctor, go back in to see your ENT specialist who you may have a relationship with. 2 weeks, that's it. It's straight over to the specialist, guys, or straight over back into your doctor. Don't linger around. So this lady has a sinusitis for greater than 2 weeks, has a rash, and the GP said septicemia, which I'm not sure about whether that's so or not.
I'm not so sure about the rash too. It would be nice if we saw the rash, but the thing is she's not improving and 2 weeks has elapsed, so that needs further treatment.
Exactly.
Now sinus infections can last, in fact, a lot of sinus infections can last more than 2 weeks.
Correct.
Right? But they may need to be treated more aggressively.
Exactly.
Heavier oral antibiotics, other things like nasal rinses. And if they're not settling with oral medications, we may take it a step up where we may give them IV antibiotics. And then in some cases, we may need to do surgical drainage of the sinuses.
But the key part there, right, viewer, is that your mom sounds sick.
Yeah.
And if your mom is sick, I think now is a good time for her to see the ENT surgeon, of course. In medicine, sometimes things take a little while to resolve, but the doctor is happy because you're not getting worse, or you might be slowly improving, but still improving. But this sounds like a patient who is sick.
Yeah, I mean, and, so improvement, improvement. Once, I mean, after 2 weeks, even if it's not improved, but you can see definitely, okay, 50% improved, you might want to extend. But if a patient starts to tell me, so I always ask that question, are you improving from the since you've had the problem? If a patient starts to think about it and I think I'm improving, no, you haven't improved enough for you. But if you're improving significally, you will tell me straight off.
I usually ask them as well. I mean, not that I'm your field, but in general
no, that's a good question.
I always ask them, give me a percentage. You're 50% better? Tell me you're 50% better. You just want to hear
when you start to want to think you're getting a little better,
we get worried.
Your mind starts to tell you you're getting better. Sometimes it might not be.
And we as doctors as well become concerned. We become very concerned. All right, Josh, so you can put up the next one. Insect flew into the air, how to treat that. All right.
So that person didn't watch last week's program.
Yeah, that person didn't watch last week's program. So we dealt with it last week, but you can still repeat the information.
Sure. Of course, a repetition is always useful, I think. So, so the first thing, if the insect went into the air, is to kill that insect. So you drown the insect with olive oil or so. You fill up the air with oil. And usually that will drown the insect and it will stop moving. So that takes away the discomfort and the pain of the insects scraping up inside there. Once that is out of the way, the next step is now to get it removed by your doctor. Last week I had said if it's a child, you should certainly go straight to your ENT.
Yeah, that's fine.
If it's an adult and it's not and it's right at the edge, you may go to your primary care, your GP, your family doctor. But certainly if there's any after one attempt or two attempts it's not coming out, you need to see us because we will need to remove it.
And then sometimes it falls out after you drown the
if it's a small insect, so it depends on the size of the insect. So if it's a small insect and you drown it and there's enough space, the insect will float out with the drops. But if it's a big insect, it's going to swell up and just block the air more.
So your doctor would have particular instruments that we use to remove these things.
Once you have the right tools, life becomes easier.
Life becomes easier. All right. So Josh, do we have any other further questions? All right. I am having problems with my ears. It tickles and I have to use a piece of tissue to tickle it, but it keeps coming back. So this guy has itchy ears. Itchy ears. How you treat itchy ears?
And that's a common problem. Every day I will see people coming in with itchy ears. And the interesting thing is a lot of them, when you look, you don't see anything in the ear. So patients will swear they have wax, they have an infection, and a lot of them, when you look, you don't see anything or anything big at all. And what I've realized with some of these common itchy ear problems would be patients actually perpetuate the problem. The skin in the ear canal is very thin, and so they get a little tickle, a little water got in, they come out of the shower, it tickles, so they scratch it. And of course the famous thing is the Q-tip, right, which we said last week don't use. But so they will scratch it with the Q-tip, or they will scratch it with their car key, or have patients who get special feathers from the chickens to scratch the ear. Right? So anything they get their hands on, they will scratch. And the more they scratch it, it doesn't pain, but it causes micro abrasions in the skin and it irritates further. So they set up a vicious cycle now where the more they scratch, the worse it gets. And so part of the treatment is actually breaking the cycle of scratching. It's not as easy as it sounds, because if somebody is sitting here and the air scratching, their hand is going to go irresistible. So I try a method and it seems to work for a lot of people. I will tell somebody, look, if your ear is scratching, get up from where you are, go into another environment, go into another room, right? Find something for your hands to do. What you're doing is you're taking your brain's focus away from your ear into something else. And usually if it's just a simple irritation, after about 5 minutes, that's
somebody else here.
Nobody will remember the scratching and you'll want to go back. So don't go into the scratching. And once you break the cycle, it eases out. Now the other thing besides scratching is water getting in. So don't get it wet.
All right. So we have a few more questions lined up, so we're going to push through.
Sure, let's push through.
Please. What causes a humming noise in your ear? Very good question.
That's a common problem too, and the medical term for that is tinnitus or tinnitus. Right? Same thing. All tinnitus means is the same thing, a noise in the air. And you could get humming, you can get ringing, you can get beating, you can get whooshing, the sound of the ocean. So you can get a whole range of them. By far, 98% are not serious, but our job is to make sure we don't miss the 2%.
What is the 2%? What causes it?
The 2% of serious cases, you could have something like a tumor in the inner ear called an acoustic neuroma pressing on the nerve. I've picked up like 5 in 20 years. So that's one of the most important ones. And the other big ones could be things like like cardiac problems can lead to that as well.
All right. So how does the patient help the symptom, get rid of it? Can they do anything?
So that's a whole topic we need a whole hour for.
We have 5 minutes and 5 questions.
So what I would say is, again, if it's a week, if it's been going for a week, you don't need to do anything for it.
Okay.
Right? Sometimes you get a little cold, your sinuses act up, it blocks up your ear, these sounds may come on a little more. You have a little wax in the ear, it might block a little bit, it comes on. So again, if it's a week or two, fine. If it's going on beyond a week, between 2 weeks, we need to see you. The other thing is if it's associated with other symptoms, specifically hearing loss on one side and dizziness. If you see that combination of symptoms, we definitely need to see you.
Great. So the viewer, the majority of times is nothing to worry about. If it's going on beyond 2 weeks, you need to see Dr. Maharaj. He needs to look and make sure that you need to see an ENT surgeon. He needs to make sure nothing else is happening there.
Correct.
All right, guys, so you can put on the next question there, Josh. Hi, good night. Is of and on hoarseness common after good night is hoarseness common after thyroid surgery?
So hoarseness can occur after thyroid surgery because the nerve to the voice box passes very close to the thyroid gland. So before every patient goes in for a thyroid surgery, we actually have to tell them up front, look, there's a 5% chance that you can get hoarseness from the nerve being damaged.
Right.
If you switch it the other way around, it's 95% chance you will not get hoarseness. But as I tell patients, if you're only 5%, you don't care about the other 95%. Right? But it can occur. Now, it doesn't mean that it will be a permanent problem. Sometimes the nerve can get a bit bruised or a little swelling around the nerve, so you can have a temporary hoarseness for the first week or so, and then it may start to improve. If the nerve gets damaged significantly, then you will have weakness of that vocal cord on one side, and that will cause hoarseness or a weak voice. It could be permanent, but a lot of times I've actually noticed after a year or two, sometimes the good cord, where the nerve is working well, comes across to meet the weak cord, and the voice actually improves after 2 years. But it can happen after thyroid surgery. I would say about a 5% chance you're looking at.
All right, so you can put up next question, Josh. Hello, good night, doctors. Just a quick question. Out of curiosity, after and during eating acidic foods or drinks, my tongue tends to burn and hurt. What do you think is causing this uncomfortable feeling, or why would that happen? Thank you.
Right. So the burning sensation basically implies that your tongue is a little extra sensitive or a little, probably a little inflamed. Now, if it's if you had a short-term infection like thrush, that could happen. If you have acid reflux, that could irritate it. If you use strong mouthwashes, all those things can irritate your tongue. It can get inflamed even after a virus.
Over-scrubbing the tongue as well.
Yeah, and that's another thing.
People over-scrub the tongue.
People like to scrub the tongue. They like to scrape the tongue. And I tell patients, look, do not scrape it until it starts to bleed. Please do not do that. Gentle, and that's all you need.
And that sometimes is a cause in general practice why people get hypersensitivity and funny feelings on the tongue.
I've had a doctor's wife come to me with vigor. She was irritating the tongue, scraping and scraping. She developed white patches. So of course the doctor sent her to me. And so I said, okay, we may have to biopsy, but let's stop the scraping and strong mouthwashes like Listerine. And we stopped it, and after about 3 weeks, she settled.
All right, good. Josh, next question, please. This final question. Besides surgery, what can cure holes in the eardrum?
Okay, so nature. And what I mean by that, 80 to 85% of patients who develop a hole in the eardrum, it will heal on its own provided we do the correct things. So the two commonest causes for a hole in the eardrum, trauma, and that's where Q-tips might come in again. The other trauma that I see, and I'll bring it up here, is an open slap to the face, to the ear, right? Because the compressed air column tears the eardrum. And that happens in abusive relationships. Women will come in sometimes and tell me, well, doc, I walked into a door, and knowing the mechanism of how it happened, I can recognize the abuse, and I'd have to talk to them privately. So trauma and infections, that's the other big cause for it. So once the infection is treated, if patients got a traumatic injury, we leave the hole clean and dry. So we don't allow any water to get in there from the shower, the beach, the pool. We do not put any drops in there, and we allow it about a 4 to 6 week period. Most of them will heal on their own. Of course, if they're not healing, then we may want to start thinking surgical.
All right, cool. Doc, it's that time again. We came to the end. It flew by. It totally flew by. So, guys, we've come to the end of the show. Dr. Rabindranath Maharaj gave us a very good explanation of the head and neck cancers. Doc, if you just have, like, in 10 words, the take-home point that for the viewers out there in terms of cancers, I could start you off. 2 weeks What else?
Painless.
Painless.
So painless 2 weeks, and symptom-wise, any symptom.
Any symptom.
Any symptom.
All right, guys. So yes, we'd just like to thank Dr. Rabindranath Maharaj. She gave us a little two-part mini-series on ENT conditions, and it was fantastic. I would just like to thank Josh for producing the show tonight and pushing through the questions. I'd like to thank each and everyone at you at home for sending your questions and interacting with us. And we'd just like to wish each and every one of you tonight a very pleasant evening. Take care. God bless. I would like to wish Maria Jose Roopnarine a happy 5th birthday. Take care. Good night, everyone. Yeah, her birthday today.